Hey YouTube, it's Marita and welcome to another edition of the Nurse Lounge. And in this edition, we're actually going to talk about something that a subscriber wants to know specifically about how to transition or what tips that I have for transitioning from one specialty area to another. So if you want to see what we're talking about, you got to stay tuned. All right, so I'm going to jump right in. I have a note card well, not per usual here lately, but I have a note card. So again, this video was requested by a subscriber, and she basically wanted to know what tips that I have for going into OB nursing. She is a med-surg nurse, I believe, or formerly a med-surg nurse, and she's finally got her a job that she's wanted in mother-baby. So she wanted to know what tips that I have regarding making that transition. What should she know about being a new OB nurse or mother-baby nurse or whatever she happens to be, considering she is transferring from med-surg. So the first thing I have is being open-minded to learn. So basically that basically means that kind of have a clean slate when you come to OB. There will be some skills in which you will transfer over into OB, but for the most part, a lot of those things that you'll leave behind. There are certain things that you'll need to know how to do, like how to use a bladder scanner, or maybe an NG tube for some of your antepartum patients who have hyperemesis or things like that. But a lot of your skills you will not be using. Besides starting IVs and things like that, you will not be using, because our patient population is just very different from a med-surg floor. So be mindful of that. I said bring your skills. So again, those skills that you already have, such as your bladder scanner, know how to use that. Knowing how to irrigate a Foley bag, knowing how to start IVs, which most nurses know how to do. NG tubes are a big one that I've only did maybe 3 NG tubes, 3 or 4 in my whole 15 years. So you best to believe anytime that we need an NG tube placed or something like that, I go to my med-surg nurses. We'll call them on our 5th floor and say, hey, can you come down and help us insert this NG tube? So that's something to be mindful of. You have unique skills already that you've used in med-surg, but a lot of them you will not have to use in OB. So you'll see them far and few between. One other one that I was going to say was, what was it? It's going to come back to me. The bladder scanner. I can't think of what it is right now, but I will definitely mention it when it comes to my mind. I can't think of what it is. Oh, PCA. That's what it is. We use PCAs all the time. So a lot of us don't even know how to set them up, though, because they come to us already set up. So our patients come to our floor with the PCA already set up already. So we, me, myself included, don't always have the ability to say, oh, this is how you set up a PCA. So you'll probably know how to set up a PCA better than most of us, especially if you're coming from ICU or coming from PACU or same-day surgery or step down, places like that. You will already know how to set up PCAs very well. Me and postpartum, we don't set them up. They usually already come to us already set up from either PACU or from L&D. I can't even read my own writing. So ask questions. Already know that you may only get a 1-month orientation. So that's the biggest thing. Keep in mind, you're already a nurse. So they're going to expect you to come down with a certain skill set already. And the biggest thing they want to teach you is how to get acclimated to your new unit. So they may only give you, I've had nurses who we've come down from 5th floor, which is our med-surg floor. They've only gotten 2 weeks of orientation and they were on their own. So, and if they did have a whole month, it's because they did 2 weeks during the day and then 2 weeks at night orientation, and then they were on their own after that. So be mindful, if you don't think you have caught on to what needs to be caught on to, that you request more time for orientation, because they will get you in and get you out and get you ready to care for patients independently within a month typically. So check around. I'm not saying that's true for everybody, but just check around. One thing to know, Barometric pressure and full moons. So, you know, those are certain things that we in OB know a lot about. When the barometric pressure changes, so we have a lot of rain, we already know for whatever reason that's going to bring in a lot of laboring women. So I don't know what it is about that. The full moon, you all know with OB and with psych, and with dementia, which is part of psych, that full moon comes, you know that you're going to have some problems. We all hate the full moon. So when we have a full moon, we actually have more deliveries, more moms come in to have their babies. And the reason why is basically before they had actual calendars like we have today, where, you know, you can say, okay, I'm actually due on March 5th or whatever day it happens to be. They had to go by the lunar moons. So by the time you had the 10th lunar moon, you were having your baby. So they knew to count the moons back then. So you stopped having a cycle at a certain point in time. You knew whatever you were about a month or so pregnant. Now, mind you, you have your baby at the end of the 9th month, or technically the beginning of the 10th, but we call it 9 full months. So 10 lunar moons. By the time the 10th lunar moon comes, it's time to have your baby if you're having a full-term baby. Now, mind you, if you're having it early, you're having it early. But that's what the issue is with the full moon. So full moons and barometric pressure changes. And it's summertime, so these women get dehydrated because they're not drinking enough and they come in contracting. So you can expect a influx of OB patients coming in when those situations happen. Also, another time to see an influx of patients for OB is at the end of the year. So we got to have our tax babies, meaning we got to go ahead and get these babies delivered by December 31st so we can claim them on taxes this year. So we have physicians at our hospital anyway. I don't know if they do this anywhere else, but we have an influx of people trying to have that baby before December 31st. So you'll see an influx of that as well. Be mindful. Babies are born at certain times because they're made at certain times. That's another thing to be mindful of. So you're going to sometimes have an influx for no reason. You can't think of what date it is. It's not a special, you know, time of the year. You have to think, was there any kind of, like, I live near a military town. So anytime our soldiers get deployed and they come home, you best to believe 9 months from that, we're gonna have a baby boom. So we kind of count back to certain things in time, like what happened. So we've had tornadoes where we didn't have any power for a while, and we start counting back, like those are those tornado babies. Or we start thinking like, that's Valentine's babies, or those are the New Year's babies. So we have certain times where you'll know there's an influx. And if there's any kind of natural disaster where people ain't working or they don't have nothing else to do, you best to believe there's gonna be babies about 9 months later. So be mindful of those things. Those are some things that you will definitely see changes in. Another one, you know, most people think that OB is a happy place, and I have plenty of videos on it, how happy it can be and how not happy it is. Keep in mind drugs. Specifically, this nurse is coming from Med-Surg. I'm sure you've seen your gamut of drug people, you know, women and men and women. However, in OB, keep in mind it impacts the baby tremendously. So you will start seeing a lot of drug moms depending on where you live and, you know, how prevalent it is where you are. I live in Tennessee. We rank number 3 in terms of the opioid crisis here. So therefore, we see them all the time. Drug moms all the time. Babies who are withdrawing, and we're doing NAS scoring to see, you know, if they are truly addicted or withdrawing from whatever the drug of choice is for mom. So drugs is something you'll see. The nurses in OB can be kind of cliquish. Something to be mindful of and be prepared for. They are kind of cliquish. So L&D nurses in general are very cliquish. Nursery nurses are kind of cliquish. Postpartum, or if you do mother baby, they can be kind of cliquish. And so we're cliquish anyway as nurses, but they are special. They're a special kind in L&D, in OB specifically. I will say that when you go from Med-Surg, I'm speaking specifically to who I'm talking to, who's actually going from Med-Surg to OB. Your Med-Surg friends are going to look at you, or colleagues are going to look at you as if you're going to the floor that nothing happens. They really don't work on that floor. So you may be actually ostracized in a certain kind of way, because I feel that from my experience, when I have to float to Med-Surg, they feel like we're not really nurses because of the fact that our kind of work is different. Like, we don't work hard. We work very hard on our floor. We just do different kinds of work. And I've had to even say to some nurses, you come to my floor and deal with the postpartum hemorrhage. You come to my floor and have to take care of 6 and 7 patients without a tech, where we do everything before we get our patients up. We do our own IVs, our Foleys, everything we do for our own patients ourselves. I'm not saying every floor is like that. Most floors have techs, but ours do not. So we do it everything on our own. So keep in mind, you will have to deal with not specialty, but people who are very cliquish, people in your former positions or former specialty area who think you are going over there to the happy place when it's not always happy. So you may be looked down upon, you may be frowned upon, you may think that you've made the best move, and you probably have made the best move for you. But just know that everybody's not receptive to either you coming in, or meaning the nurses who you're going to go work with, or the people that you've just left think that you're coming to do much of nothing. So just be mindful of that. It kind of goes that way. When it comes to the babies, be mindful that their heart rates are high. They have to be over 100. So in your whole med-surg mindset, or wherever you come from, for adults, we typically want their heart rates below 100, between 60 to 100. And if they're dehydrated, they can be kind of tachycardic or whatever, which that can be normal depending on the situation that they're in. In med-surg, I'm sure you've seen heart rates in the 120s, 130s, or whatever. But for babies, we want them over 100. So therefore, you're going to have to kind of retrain your brain to think babies' heartbeats are fast and they breathe fast. And we should be counting, actually, you know what? I'm going to do an assessment video for moms and for babies in the future. So, but we should be counting heartbeats for and respirations for babies for 1 entire minute. Don't do that 15 times 4 or 30 times 2 when you're counting for 15 seconds or 30 seconds times 2. If you need a quick, just number, then maybe you have to. But when it comes to truly knowing what a true heart rate is, you need to count for the entire minute, because babies' heart rates and babies' heart rates can be a bit irregular, where they go real fast and then they slow down. And if they're crying, they're definitely going to be even more. And that's another thing. If they're crying, you're going to have to find a way to be able to listen to their heartbeat without missing the beat and tuning the crying out. And that's very hard to do initially. You just hear all the crying. And mom's heart rates usually between 60 to 100. However, if they're dehydrated, we have people in the 120s, 110s, 130s. We just have to watch and monitor for that, and just know that's not normal per se. But at the same time, it's just something we have to watch for. If they've had surgery and they're dehydrated, you expect the heart rate to be higher. Also, when it comes to our patients, I put on here, they're relatively well, but they can be sick. So we have people who have high blood pressure. We have people who have thyroid issues. We have people who have mental health issues. So you're going to see your psych here. We have people who are homeless. So you have psychosocial issues. People who have been abused, things like that. So keep in mind, we have women who have been mistreated, who are currently being mistreated. We have people who are same-sex couples, people who are adopting their babies, who are give babies up for adoption. We have people who are surrogates for other people. So you're going to see a gamut of all kinds of scenarios that, that's going to play out at the hospital. So just be prepared for that. Moms are tired all the time. So be prepared for the hormone changes and for them to tell you they're tired. Our patient population, the demographics from about 15 or younger, sometimes 12, 13, 14 to 40 plus. So the childbearing ages are from like 12 to 40 something. So that's your patient population. So they're relatively young. So there's no men, with the exception of the fathers, who are present. But for the most part, your patient population, 15, 12, 13, 15, whatever, to 40 something is what you're going to be seeing. So think about Erickson's stages when we talk about these different things. What is a 15-year-old going through? What stage is she at? Comparatively to someone who's 40, what stage is she at? So those are things you want to be mindful of when you're thinking about your patient population and how you're caring for them. 17-year-old girls don't want to be bothered half the time. And sometimes, they got their boyfriend up there and they don't know what's going on, and the boyfriend's cheating and carrying on, and it's just all that plays out at the hospital. Just be mindful that you have to be that good nurse no matter what, and take care of your patient and try to work with them, and just understand they're crying for no reason. It's hormones, and just, it's not always you. Sometimes they don't be bothered. Sometimes they want you to come in. The good point here, these patients want you to come in, get your job done, and leave. Whereas your geriatric patients or your older patients may want you to come in and talk to them. So you always get caught in a room talking to them about whatever. They want to tell you their stories. Some of these people don't want to be bothered with you. So come in, get your work done, and leave. Make sure when you walk into your patient's room, you're walking in with a purpose and not just, well, we have to do hourly rounding, but outside of that, that you have a purpose. It's not just like, well, I just want to just see, what you're doing. Some of them you will learn will appreciate that, and others don't even bother with them. They'll tell you, don't come into my room. So keep that in mind. Some hospitals, or most hospitals, have moved to couplet care. So be mindful that you will have more than likely a mom and a baby, depending on the situation, if the baby's not in NICU. Some hospitals do 3 to 4 couplets, which means you'll have 6 to 8 patients. And in theory, it's a great thing to have mom and baby together at all times. And I will say that in theory, that's a great thing. But in reality, for me personally, I do not like couplet care. I've said that many times. I cannot stand couplet care because we do not have your run-of-the-mill normal patient situations. If I have a mom who is on drugs and she's getting Suboxone or methadone or whatever her drug of choice happens to be, she's getting maybe still Lortabs because that's what the doctor wanted her to have. Well, she is feeding her addiction. She is feeding what she needs because she's still getting something. However, that baby of hers that I'm caring for while I'm watching it withdraw is not getting anything. So we want to encourage her to breastfeed so the baby's getting something. But then the baby has that high-pitched drill of a cry that, sometimes that moms can't stand. And I've had a situation where we had couplet care going on, but she was literally about to shake her baby because she could not stand the crying. And so I had to take that baby away from her because she would have shook her baby. With couplet care, there's typically not a nursery. So there's no nursery means you, the nurse, has to babysit that baby. Mind you, you have 3 or 4 other babies, or 2 or 3 other babies that you're caring for, and 3 or 4 of the moms that you're caring for. So who's going to sit there and watch that baby for you while you're going to do this, that, and the other? All the labs that have to be drawn for that baby in terms of the billies have to be done. The PKU has to be done. You have to do that. Car seat testing, if it has to be done, you do that. The hearing screen, some places they do their own hearing screen. Some places they have somebody come in and do them. Some places you have to do a heart test that they do on the baby. If it's an NAS baby, withdrawing neonatal abstinence syndrome, you have to score that baby until it gets a score high enough to go to, say, the NICU. You have to do all those things. So you're monitoring the care for the baby as well as the care for the mom. So you're interacting with 2 different physicians, the OB as well as the pediatrician. If the baby's a boy and she wants the baby to be circumcised, you, the nurse, unless they have a tech or somebody there to watch or oversee, you have to go and attend the circumcision and be the assistant to the physician. Meantime, while you're doing that, who's taking care of all your other patients? Who's watching other patients? So be mindful. That is kind of how couplet care works. It can be complicated, but if you have a good team working with you, if you have a good charge nurse and a good, good nurses working with you, then you can easily be able to navigate that if you have somebody who's truly has your back and watching your patients for you. I put on here that it's very fast paced. Well, it can be. It's feast or famine in OB, at least at our OB. So there's days where, you're going to, for me, Wednesday through Friday, we are going to work our tails off. And on my floor, we do antepartum, and we do GYN surgery as well. So we don't do couplet care. We do postpartum, antepartum, and GYN surgery on my side of the floor, on our postpartum side of the floor. L&D is its own entity, and nursery is its own entity. NICU is its own entity as well. So we do all those things on our floor. So we do a lot of education. There's something else I wanted to bring up. We do a lot more education than you probably do on your med-surg floor. People coming in for a diabetes situation, they gonna come in and do whatever they gonna do. You can sit there and say, okay, you need to take your blood sugar, I don't know how many times a day. You need to watch what you're eating. You go over their diet with them, or whatever the situation may be. They go into the house. With us, we do extensive teaching, or at least we do extensive teaching to our moms about the care for them, the care for the baby, what to look out for, when to come back to the doctor, what we're going to do about birth control. We explain to them that you can get pregnant very easily after having a baby. Some people don't know that. Some people don't know that breastfeeding is not a method of birth control. So we have to emphasize that you can get pregnant. We give the immunizations to our patients. So we give Tdap, we give flu and flus in season. Some places give pneumococcal vaccines to those who smoke. You will have smokers. That's another thing. You have smokers who absolutely want to go off the floor to smoke. You have to follow your policy or whatever it is at your facility. We have a no smoking facility. So our patients are not allowed to go off the floor to go smoke. However, some of them sneak off and go smoke, but it is what it is. I just document accordingly. I want to say, what else about OB? Uh, just know it's different. It's very different. I feel that, you know, if you really like moms and babies, will be just fine. As long as you keep in mind that everybody is just not receptive to, you know, the same kind of care. And be mindful, people have different backgrounds and, you know, walks of life, and they've come from different situations. You have women who are very promiscuous and they keep having babies year after year after year. You have those women who are very traditional. You have what we call their granola moms. Granola moms for us means that she is like of nature. She is the one who takes her placenta home. Something else. Some of these people like to take their placenta home. So you have to keep it on ice and this, that, and the other. They either encapsulate it, they bury it, they do whatever they do. If they encapsulate it, that means you're going to take it for to ingest it, because it's supposed to help with postpartum depression and things like that. So some people go to do that and pay to get that done, and some people like, no, you know, no thank you, just throw that out with everything else. So be mindful that this is just kind of how OB is. And so hopefully some of these tips have helped you. Oh, one more thing, medications. We typically don't have a whole gamut of medications that we give. The biggest thing that we give medication wise is Colace, which is a stool softener. We give Motrin for pain, Tylenol for pain or headaches or fever. We give Lortabs, Percocets, Tyloxes, which is a form of Percocets. What else do we give? Norco, which is Lortab. We have different names for different things, but basically they're the same medications for pain. For IV medications, we have the D, of course, Dilaudid. Everybody loves the Dilaudid. We have morphine and we have Toradol. Toradol is my favorite. I really wish they would give everybody Toradol. Toradol is kind of like an IV Motrin, basically. So we give everybody, I wish we gave everybody that would cut back on their pain, the C-section patients anyway. C-section patients, that's what I was going to say. So C-section patients are surgery patients. So if you're used to having surgical patients, that is what she is. She just happened to have a baby via that route. So she's going to be in pain. She's going to have to get up and move. You're going to have to do your incentive spirometry with her. She's going to have SCDs on. In some places they do TED hose and SCDs. She's going to have to, you're going to have to monitor her incision or make sure that it looks good. Make sure her dressing is clean, dry, and intact. She has a Foley typically for the first so many hours, whatever your policy is. They have an IV typically for the first so many hours. We give antibiotics quite frequently to our patients. Of course, if they have hypertension or on different kinds of disease processes, we give medications for those. So antihypertensives, we give, they throw up, so we give them antiemetics. They get Nubane. I give Nubane quite often for itching. Actually, is our first. At our hospital is our first drug for itching, and then after that we give we give Nubane and Benadryl. We give both of them. So we give that. We have to be mindful of their diets, clears, regulars, whatever they're on. Typically clear or regular, or NPO for whatever reason. So that's the gist of it. I want to say that's pretty much it. We stay busy. I would say for us, there's never a dull moment on our floor. I do think that you will enjoy OB if this is what you really want to do in life. It's not for everyone. Be mindful when it comes to our whole assessment. We don't do, at least at our hospital, I'm speaking for my hospital, we're not playing in people's heads and things like that. I don't even think we do Perla. Well, I already know we don't do Perla. So we don't have pen lights trying to do this. One time we did do it because our patient went blind on us. But outside of that, we don't do, I don't even have a pen light. Matter of fact, I have to go find a pen light. So we don't do Perla. We don't do, you know, the strengths when you do the grips and stuff like that. We don't do that on our floor. If that hospital that you're at does that, then do whatever they have you do. But we don't do that. We don't inspect people's mouths and things like that. You can pretty much know when talking to them whether they have teeth or just their mucous membranes or things like that, how that is. But for the most part, we do the rest of the assessment. At the end of the day, I tell my nursing students, we only focus from the breast to the vagina is all we care about. Everything else, we sure it's working. You know, it's either working or it's not. The breast to the vagina is our biggest areas that we focus on, and really the fundus in the vagina in terms of what's coming out. You know, how much blood is coming out. We monitor their blood. And the one thing that I find that students have the hardest time with, that maybe even med-surg nurses or people who don't deal in this area, is we look at vaginas all day. Be ready to say that word quite a bit, or be able to say a word that you can use. I'll say, I need to look at your bottom. I need to look at this, that, and the other. I just call it what it is, a vagina. So it, you know, it just kind of slides off like that. That's our world. We look at vaginas all day long. So be able to say that with ease. If not, just say, I need to look at your bottom. I need to look at your peri area. I need to check your pad. And like I tell my students, if I don't look at nothing else, I have to check that, because that's what's going on. Another thing, hygiene. All women are not created equal. We do not all practice the same hygiene practices. Now, mind you, you just had a baby. We get that. But there's situations in which you just had a baby, but you hadn't washed still. You knew, we've had people who were scheduled inductions. Scheduled inductions. They mean they knew they were coming in to have a baby, or scheduled C-sections. They were coming in to have a baby. And for some reason, they did not bathe before coming in. When I had my babies, I took very good showers, make sure I was very clean before it was time for me to be induced, or any doctor's appointment. Matter of fact, I would make sure I was really clean, because I never knew that could be the day. And of course, they're going to check down there to make sure that everything is, you know, okay. So you're going to have people, women, who are not that hygienic. They're not that clean. So you have to be mindful of that. And you have to teach them about keeping their bodies clean and being hygienic. So be mindful of odors and things like that. And I think you'll be okay. So if something specific you want to know, definitely put that comment down below, or send me a DM on Instagram. You'll see that link in the bar, in the YouTube, not bar, what is it called? Whatever the thing is at the top. I can't think of it right now. Banner, that's the word. You will see the link to my IG on the YouTube banner. But if you want to leave a comment below, feel free to. If you want to email me, that's also listed. So you can email me and ask me any questions you have, anything that I didn't cover. I wanted to provide a few tips or suggestions, or just things that I want you to know regarding OB nursing, especially if you're coming from another specialty. This is not really geared towards the new nurse per se. I mean, you could find it beneficial, but this is more so for someone who's coming from another specialty. That keep in mind, your specialty, your area is your area. That people are going to think things about your area, and maybe you can, you know, dispel some of those myths about your area when you come to when you go to OB. And maybe, you know, people think that, oh, med-surg nurses are so mean, or OB nurses are so mean, or everybody's so mean, or whatever it is to be. Just don't be that person. Just know that, you know, you'll be fine and you'll learn a lot. Again, OB is not for everyone. There's people who love OB, which is me. I love OB. I love moms and babies. But med-surg is not my thing. Psych is not my thing. We do have psych in our OB world, but psych is definitely not my thing. But I love moms and babies, and I love, you know, even the ones who are drug moms. We find resources for them to help them if they choose to seek help and stuff like that. So anyway, hopefully you found this beneficial. Leave comments, questions, comment, share, like, subscribe if you have not already. This is primarily a nursing channel. However, I do venture off and do fashion and stuff like that. So anyway, until the next time, you all take care. Bye-bye.
Let it loose, let it go.